Presenting today. I'm presenting today on countertransference in oncology and palliative care. So one of the main reasons I chose to do this is because I am new to Sunnybrook. Some of you may have heard of my name, but I only started at Sunnybrook in July of this past year. So it's been about 4 months-ish now. And before this, I started my career about 15 years ago at South Lake before they even had the cancer center. And then I moved to Scarborough and did a locum there, and I've worked in Lake Ridge Health. And for the last 13 years, I was working with the Tammy Latner team out of Mount Sinai. So some of you may have heard my name through, conversations and things like that with patients that we mutually share. So I thought that I would kind of do this so that now you kind of know who I am. And please, I know tons of names, but I don't know a lot of faces. So if you do see me, please feel free to come and say hello and introduce yourself so that I can get to know everybody. So in keeping with that, I have two sides of interest in palliative medicine. One side of interest is in ALS care, and I'm currently doing or hoping to complete a manuscript on some new research on ALS and home-based care. But in addition to that, on the other side, I'm really interested in some of the psychosocial elements of the practices that we have. So I'm interested in our own approaches to patient care, how we manage compassion fatigue, burnout, countertransference in this case, and even some of the ethical aspects of it. So what does autonomy mean when you're taking care of somebody in a home-based setting where the family is required to do all of the care? So those have been some of the interests and some of the things that I've worked on over the years. And so I thought that I would kind of introduce myself with one of those main topics, which is countertransference. So with that ado, so I don't have any disclosure. I have no actual potential conflict of interest in relation to this presentation. The only actual thing that I have related to this presentation is that I'm putting myself in this very vulnerable position because I am actually reviewing a case that was a very hard one for me personally. So please don't judge me for it at all. You'll understand why as we go through. But I think sometimes allowing ourselves to be vulnerable and showing how things affect us is the best way for us to reflect and change. And so one of the things that I wanted to talk a little bit about is, this is a presentation in oncology ground rounds. And I'm sure that many of you are kind of thinking, or some of you maybe are wondering, how does this relate? And so we certainly know that in palliative medicine, this relates because we deal with death and dying on a daily basis. Not so different in some ways from oncology. And as many of you know, there has been research that's been done on oncologists related to loss and grief. It was done, there was a bunch of studies that were done based on 20 interviews in Toronto of oncologists at different stages of their career. And one of the things that we found, or that was found in this study, is that oncologists talk a lot about compartmentalization of the challenges that come emotionally with their job. So you kind of compartmentalize things and you go to your work and then you go home. The problem is that the oncologists also say they're not very good at compartmentalizing. And I actually think that the same would go for those of us who do palliative medicine. And so one of the things that oncologists have found is that they do develop more challenges in dealing with loss and grief when they've known patients for longer, younger patients. They connect with them on different ways. And one of the things that oncologists have actually talked about is the importance of actually talking about it openly. And so I wanted to take this opportunity to actually talk about things that in studies oncologists have said, let's actually look at this information and see what we can do to make lives a little bit easier, maybe. So that's kind of one of the other reasons why I was thinking about this. But anyway, what I'm hoping to achieve at this point is to define the concepts of transference and countertransference, review a case that practically outlines how these concepts are present in the care of cancer patients, identify factors that might lead to countertransference, and pinpoint emotions and behaviors that result, and present a model for self-monitoring and reflection. And so hopefully we'll go through this. If you do have any questions or anything, I don't mind if you kind of ask. So feel free to interrupt at any time to ask any questions. I'm always interested in feedback, so feel free. So transference was a concept that was created actually by Sigmund Freud. And the idea when Freud brought up the notion of transference is that this is a really good thing. And the reason is it's because the experiences of the patient and the experiences in the doctor-patient relationship overlap. So what's supposed to happen is that the patient comes into their relationship with their clinician, and they have assumptions and belief systems and experiences and thoughts that come up based on what they've experienced in the past. So if you remind them of your sister, they are going to come up with experiences and thoughts and attitudes towards you that reflect that. And the idea in a really good situation, based on what Freud said, is that you're going to take this transference and that you're going to use it in the clinical relationship to pinpoint some of these behaviors that might be outmoded or outdated or not helpful to the patient and allow them to change, right? So transference was always considered to be a very good thing with patients. If you can actually pinpoint some of their assumptions and beliefs and systems that actually identify some of their challenges, then you actually create behavioral change for good. So, like I said, it refers to the unconscious redirection of a patient's feelings and attitudes. And for Freud, psychoanalysis was specifically designed to encourage transference. So some of you might know psychoanalysis is one of those kinds of techniques where you see people on a daily basis or regular basis, and you're kind of behind them and they make kind of comments about that. And so I always try to put in these like little comics in here. And so this one says, I hate you. And so the clinician says, what if you're just projecting? Maybe I remind you of things you dislike about yourself. And the gentleman says, no, I hate you more. So then what is countertransference? So countertransference was actually believed to be not a good thing. So countertransference was actually believed to reflect the unconscious beliefs of a clinician's feelings and attitudes onto a patient. So this was regarded as an obstacle to treatment because you would develop blind spots or mechanisms that you needed to overcome in order to do it. So a patient is kind of making an assumption about you, and then you actually make an assumption about a patient, or you respond differently to the patient based on how they make assumptions about you. And so, according to Freud, this was not a good thing. But over the years, the notion of countertransference has developed into a more benign interpretation. And so it actually reflects the experiences of clinicians towards their patients, and they could be unconscious or not unconscious. And so some people think that it's a really important phenomenon. So let me give you, and other people think that it's actually, there's good countertransference, and then there's like good emotions that come with countertransference, and then not so good emotions. So like I could have a feeling of, meeting somebody and thinking they're hilarious when they come and talk to me. And so now I want to actually make them like me. So I'm going to be really careful about how much I challenge them on some of the comments that they make. Or I might not talk to them about some of the more difficult aspects of doing a palliative care history, goals of care, things like that, because I don't really want to experience some of the things are going so well, I don't want to go through anything else. So that would be like a type of countertransference, but it doesn't cause ill regard. It's just I want to do well by this person. I don't want to piss them off because they seem very likable. But then you can actually have the negative forms of countertransference. So this person is truly irritating me, and I don't know why, but this irritation is making me want to finish this conversation sooner. And therefore, I'm not getting all the information that I need because I feel more irritated and frustrated about what's happening here. So you have a very bad case of transference is this one. I actually, sometimes I wonder if it's really transference or countertransference or a little bit of both in this one. So does anybody have any questions before we move on a little bit? Okay, so let's move on. So I'm going to actually present to you. So now that we've kind of talked a little bit about the notions of transference and countertransference, I want to bring up a case, and this is a case of Judy. And I have to admit, this was one that I did in someone's home. But I think the concepts are the same no matter where you do it. And so that's what I really want to bring up for everybody. It's not the like where or why or how, it's the concept. This is not really Judy, and this is not really the patient's name, but I always think that it's nicer to actually put a face to a name. And so that's how I decided to do this. So this is Judy. So Judy is a 92-year-old with locally advanced thyroid cancer that was diagnosed about 3 weeks earlier. So she had been in and out of the hospital for heart failure. And while in hospital during her most previous episode, she developed a hoarse voice and difficulty swallowing. Seen by ear, nose, and throat, and it was suggested that she likely has a malignant thyroid tumor with spread locally, but Judy declined any further assessment. And so, her past medical history, you can see there. So the first thing that always scares me is when people come up to me and like, I'm not patting my back, I promise. So don't think that. But people say like, oh my goodness, I've heard amazing things about you, because that to me is already like an experience of countertransference for me. Like, oh my goodness, now there's strain. Now there's pressure. People are expecting something of me that I have to keep going. So that is always a little bit of a pressure cooker for me. It's always something that I actually would prefer not to hear. Nevertheless, so you can already see in that sentence alone that there is something to worry about. Now, in home-based care, I don't know if anybody, so I've kind of coined a term in home-based care, which I don't think anybody else would know about, but everybody who does home-based care knows about. And it's called the porch sign. So when somebody is standing at their porch or standing at the elevator or standing in front of their house waiting for you, it can never be good. So I call it the porch sign. And everybody who has heard me say, oh my goodness, I had a porch sign today, knows exactly when they're doing home-based care what this is. So this was actually a bit of a porch sign to me. And I wish the foreboding had kind of, not been there, because it got worse. But I will keep going. So this was a patient who was born in Hungary, and she was a survivor of Auschwitz, and she had 2 children, a son and a daughter, 7 grandchildren, 10 great-grandchildren. Her husband died about 4 years earlier after a very lengthy disability. And Judy herself is Jewish and traditional, but not Orthodox. And her daughter was not religious at all. So identified as being Jewish, but not at all religious. And her son and daughter-in-law were Orthodox, and they followed all the Orthodoxy traditions that are done in the Jewish community. And that can be very different for different people. So when I was there, the issue for her was pain and profound difficulty swallowing. And she was even aspirating thickened fluids while I was there. And we had a very nice conversation with Judy and her daughter. Her daughter was the only other person there, about her goals of care. And she made it very clear. She did not want to be resuscitated. She did not want hospitalizations. She did not want a G-tube. She'd consider antibiotics for an infection, but not eager to prolong her life, believing that she's lived a long, satisfying life, and that comfort is ultimately paramount for her. So very, very clear goals of care. So the next day, here's where the porch sign really comes into play. I get 3 phone calls. The first phone call is from Judy's son, and he's irate because he believes that his sister has told Judy what to say, and now she doesn't actually want to have, and she doesn't really know, according to the son, what she wants. He feels like he's been betrayed because he should have a say in the matter as well. And he's arranging follow-up because how could somebody not want to try to live longer if they could? Judy's sister calls me to let me know that her brother is irate and that she can't convince him that these are her mother's wishes. And then a physician who is a family friend for whom I received, permission to speak to, he was calling to inquire about how these decisions were being made, who was making them, were they decisions that the patient herself was making, was she kind of under duress at the time, and how in the world could somebody not want to inquire about further treatment and management? So this can be very common. I mean, the Jewish Orthodoxy would say that you do everything you can to prolong life. And so that would be quite consistent, as long as it's not hurting you, is really the Orthodoxy. So, and so that would be consistent with that. And Judy's daughter is kind of saying, but my mother is not of that kind of, does not have the same belief system, and she's not interested. So what do we do? So what do? I go back to the family home to have a meeting with the family. So at the family home now was Judy, the son, her daughter, and the daughter-in-law. So there was 4 of us there, and we reviewed with Judy at length the diagnosis and the options for treatment, including a biopsy, radiation, and G-tube. And in front of the entire family, Judy kind of says, I don't want this. I don't want to be a burden to my family. And the family says, but Mom, you're not a burden to us. We want to do this because we love you and we want to take care of you. And then she says, but I don't want to be a burden on myself. I don't want this. So I'm 92 years old. I've had a good life. I have a wonderful family. I'm ready to go. I do not want to battle this. I want to stay at home and let things be. So we moved to another room because the family she was getting tired. She didn't want to talk too much more. And the daughter was in complete agreement. And the son did not believe that his mother understood that the treatment could improve her symptoms. And so he was still not sure that she understood that with treatment, she might get a little bit better. But the daughter-in-law was furious. So Her response was, you don't know Judy like I do. You can't imagine loving someone as much as she is loved. You can't imagine what we are currently experiencing. She doesn't know what she wants. She's never been able to make a decision. She felt that it was unethical to not do something. You have to do something. And insinuated that, like, me as a Jewish woman, I must be a bad Jewish woman for not advocating that something should be done. So this was like a barrage of frustration, disappointment, and everything. And so, do you know what I did? I know, like, in real life, somebody can actually say, but does anybody want to know what my response was? Well, I'll tell you. So again, don't judge me. I cried. So I actually started crying in the home. And people say to me when I tell them this story, they're like, oh my God, what did you do? And it took me a long time to pull myself together, to be honest. Like, I wasn't just like a little teary. I was like tears streaming down my face, having a difficult time talking. And I basically finally said something to the effect of, I am so moved by how much you love and care about your mother-in-law. And so the daughter-in-law then rushed out to a meeting or something like that. And I stayed. And so Judy at that point was able to sense tension in her living room and called her daughter, who came out with a dictated note. I do not want treatment. I do not want radiation. I have had enough. I want to be with Daddy. And so, anybody have any questions about that so far? So really, ultimately, the daughter, after that, the daughter and son calmed down. They agreed that they were going to work together. They decided that they were going to see if they could get another opinion to see what could be available for her, and then they would decide from there. And as it turned out, Judy declined another opinion. She stayed at home, and she died comfortably at home. So when I think about, so this is based on research, this is not based on anything else, but when I think about risk factors for countertransference, so let's kind of look at them. And I usually look at risk factors. I look at everything. So my background is in anthropology, medical anthropology, and I look at everything within a grounded theory of physician factors, patient factors, situational factors. How can we look at this in all these factors to understand what might cause countertransference in us, right? So here I am, having just cried in front of a patient, big from my perspective, that was a big fail. Not anymore, because I've kind of reflected on it and learned something from it, but at the time. And so the physician factors that we think about with countertransference is, as I mentioned before, and as the research studies show with oncologists, identifying with patients, dealing with an ill family. So you have your own ill family member, or you're dealing with grief, feelings of failure, which can happen, which studies have shown oncologists often will feel, because if a treatment fails, there's always some kind of sense of, oh no. Same with palliative care doctors. If I give somebody pain medication, it doesn't work. There's always that feel of failure as well. Unconscious reflection of feelings originating and expressed by the patient or family, inability to tolerate ambiguity or uncertainty, fear of death, disability, psychiatric illness. And then there's the patient factors. So they're angry or distressed. There's a medical or healthcare professional. A patient is a medical or healthcare professional. They're well known. Complex dysfunctional family dynamics, mistrust. And then there's the situational stuff, which we don't have any control over, really. So it's the time pressures, disagreements, hospitalizations, conflicting professional obligations, long, close physician relationships. And ironically, when you look at the research on oncology grief, and I'm sure palliative medicine grief, these are many of the factors that prohibit us from being able to compartmentalize our emotional experiences. So what happens when you experience some of these, when you click into some of these experiences? So you have behavior and you have emotion. So your behavior is you avoid the patient or the family. You don't communicate effectively with other professionals. You dismiss or belittle the remarks. You either contact patients more often than medically necessary or less often than medically necessary. And then emotionally, you're like, there's the irritability and the dread of making a phone call. You feel harassed, you feel contempt for patients and their families, you feel a sense of failure, blame, guilt, personal obligation to save the patient from something. And this is what it turns into, right? We have this horrible experience. We think about this horrible experience, and then we're like, oh my goodness, I do not want to have to deal with this family again. This is one of the most embarrassing experiences of my life. And so let's look at Judy for a second. Let's go back to her and her experiences. So in my case, if I go to the risk factors for countertransference, so I'm going to break this down for you. So when I think about the physician factors that cause this for me, my grandmother was Hungarian and fled Hungary. So she sounded and had white hair. So she sounded exactly like my grandmother. She spoke like my grandmother. She reminded me of my grandmother. And so I kind of had this, like, I was seeing my grandmother a little bit in this situation. So obviously there's a sense of inadequacy or failure. Here's the other one that was the key, though. My father had died 6 weeks before this happened. And so I had taken off about 4 or 5 weeks, and this happened in the first or second week that I got back to work. And so when the daughter-in-law is saying, you don't know what it's like to love somebody as much as we love her, and all these other things, obviously that hit a really, really big nerve. And then there was the other factors, right? The complex dysfunctional family dynamics, family members disagree over patient management. So there's conflicting professional obligations, right? I want to make sure that everybody is happy. My job is to actually support the patient, who was very clear in all of her wishes, and yet at the same time, you have a family that's not happy. And increased ambiguity, uncertainty about prognosis or patient care, because at the same time you have this doctor who's known to the family and knew the situation, who's calling saying, like, you've got to do something. Of course you've got to do something. Why aren't you doing something? So there was a lot of risk factors here for me experiencing countertransference. And then what I experienced as a result was physical signs of stress and tension when seeing the patient or the family. I felt imposed upon, harassed, embarrassed, victimized. Certainly felt blame, contempt, all those things, right? And you don't actually need this in particular case in order to kind of figure out what the issues are, right? There's many cases. I have had cases in which patients have called me asking for an urgent visit, and then you go there and they're basically like, I need an urgent visit because my stoma needs to be changed. And they're in a retirement home. The nurse is there. The nurse is able to change the stoma, but they wanted me to come to change the stoma bag. So, there's all kinds of situations in which you can sit there and think like, oh my goodness, I've had a couple of patients take their own lives, not through MAID. And again, those are always cases in which the grief and the experience of it, certainly sense of failure. How could I not know? How could this have happened? What did I do wrong? all these things come up all the time. And so I think it's really important to be able to recognize what the factors are that lead us to feel that way, and what the behaviors and emotions are that cause, like, that stem from those reactions. And so, just to lighten the mood, you're not as clever as you think, or you're not as clever as you think. So they're both thinking the same thing. So does anybody have any questions or anything before we move on? Okay, so self-monitoring and reflection to manage countertransference. So this has actually been a study by Diane Meyer. Diane Meyer is a very, very well-known palliative care physician in the United States, and she did a study to look at how we can manage these things. So the first step is to identify your risk factors, right? So what are the risk factors that are going to predispose somebody to countertransference? And what are the behaviors and emotions that indicate that? So we've just actually gone through that very clearly. Then the question is, name and accept the behavior or the emotion. So I feel guilty. I feel like a failure. I feel like I've done something wrong. And identify the sources for the countertransference. So I basically, in that situation, was, was confronted with all the things that I hold dear, right? So who I am religiously was questioned, who I am as a doctor was questioned, who I am as a caring physician, who I am as a caring daughter, because I had just lost my father. Every single thing that was said to me in that situation kind of made me question everything about myself when I was already in this very vulnerable scenario. And so the question becomes, how do you respond constructively to the presence of the countertransference? So, in that situation, I really was able to pull myself together after the daughter-in-law left, and be able to kind of sit down with them and figure out what a plan would be that would be okay generally for the mother, but yet at the same time that would appease all the parties sufficiently so that there would not be the same kind of tension in the family. And so stepping back, so that's kind of how I left it. But when I step back from the situation to gain perspective, and I identify behaviors resulting from the feelings and consider the implications or consequences. So you think through the alternative outcomes, and then sometimes you just have to ask somebody, like, what do I do right now? So for example, let's kind of move forward. So if you're thinking about all these things again, so these are the risk factors for countertransference, and these are the behaviors and emotions that I personally felt at that time. And so these are the things that you're supposed to do. And this is what I did. So I stepped back from the situation to gain perspective, and that involved, after leaving and thinking about it, why did I react the way I did, right? And I do that all the time now. Every time I have a weird reaction to somebody, I get a little bit, I'm pretty patient with most people, and super patient with the people that I see professionally. And so if I'm starting to get irritable or frustrated or feeling, some kind of threat of some sort, even minor, when it's done, my first thing is, why did I react the way that I did? And sometimes it's just because I'm tired. And then I know that oh, I'm really tired, not on the day, because I can usually get by, but I'm tired. I need a break. I need a holiday. I need some time off. And so sometimes my irritability has nothing to do with, is really, there's countertransference because I'm tired and I need a break. Other times there's something more to it. And so then I identify behaviors resulting from the feelings. So like in this particular case, the idea of having to speak to this family again was actually mortifying. So I would get palpitations, sweating, and shaking when speaking with the family thereafter. I felt like I needed to explain my behavior to the family. Like I felt like, oh my God, if they just knew that my father had died 6 weeks ago, maybe they'll understand, which is, obviously completely inappropriate as well. But that's where your behaviors come. Consider the implications and consequences of my behavior. So did I lose rapport? Did I lose trust? Maybe I came back to work too soon. And then think through alternative outcomes for the patient based on applying different behaviors. So can I, at this time, change the way I behave with this family, or do I need to do something different? And so in this particular case, and this is, I think, the only time I've ever done this, I actually realized that I couldn't do it. That I had come back too soon, wasn't the right time for me, and that I was just too kind of emotionally, I don't know what the word would be, so I actually spoke with a colleague who took over the case, and I actually took more time off so that I could kind of reflect a little bit and come back in a little bit of a different framework. And so that is kind of how you do it. Now, you don't always have that opportunity, right? You don't always have the opportunity to kind of say, I can't do this. This is not going to be a case that I'm going to be able to go back to. And in fact, every time I think about this case, I still get dread, and like my hair goes up in the back. And I still feel like, oh my goodness, but like I also can recognize that this was not my best moment, and there are reasons for it. And so really in this situation, I was kind of in a very fortunate situation that I was able to. Some people are not. And so sometimes we do have to just kind of trod through and kind of figure out how I'm going to work this out afterwards, and how I'm going to approach the situation, which really gives me so much distress, in order to try and maintain some level of professional boundary development and not feel like I am taking what they're giving me and putting it right back on them. So, in summary, and finish a little bit earlier than usual, but in summary, we do not learn from experience. We learn from reflecting on experience. And that was the whole point to this presentation. How can we do the work that we do with the intensity that comes with it, and with the recognition that we all do compartmentalize things, but don't always do it in such a great way? What are some ways that we can work through it so that we understand our behavior better, and then we can adjust, right? So that we don't experience compassion fatigue or burnout, but we actually are able to say, I know I am having this reaction to this patient because I think I would be friends with them if they weren't coming into the clinic here. Or I think that they're hilarious and I'd love to get a beer with them. Do you know, like, how do I kind of negotiate some of these close relationships that we develop with people in a way so that we can continue to do our work when that work gets harder? And so in conclusion, countertransference is a phenomenon that readily occurs in the medical management of vulnerable people, including palliative care and oncology care. As healthcare providers, we need to be able to identify the risk factors that influence countertransference and be able to identify the behaviors and emotions that come to us as we are experiencing our emotions from them. and then self-monitoring and reflection. And again, the one thing that I want to say is countertransference doesn't have to be bad, right? It doesn't have to cause us, as I said, it doesn't have to cause us irritability or strain. We could look at it and say, maybe this relationship that I have with them, where I like them, makes me want to do better. And maybe then you kind of say, well, for this patient that I'm not so keen on, would I do this for this any other patient, right? And that's what I do a lot of the time. If I'm going to look at this person and do this for them, would I do it for anybody else? And if the answer is yes, I would, then regardless of how I feel, I'm going to try and do the same thing. So that is the end of the presentation. I don't know if anybody has any questions or comments or anything like that. Anything? Yeah, Sarah.
Jen, thank you so much for such an honest retelling of a very difficult situation that I'm sure many of us in some ways can relate to. So yeah, much appreciation for your candor. I'm just wondering, and if it's a simple no, it's a no, but just like with your anthropology background, I'm just wondering if, like, I'm trying to imagine kind of, 100 years ago, how we used to practice medicine in much more of a paternalistic way, and the medical tech wasn't where it is, and whether I'm imagining a situation where some of this, in many ways, is becoming more and more as time goes on, because I feel like there's so many demands on us now, and I feel like our patients are looking things up and asking us for things that didn't exist before the internet, and for a slew of many, 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 many reasons, I feel like it is a lot, and I'm just wondering if you have a sense of like how that might have evolved with time.
Well, I think, medicine has evolved so that instead of, as you mentioned, like the paternalistic side, we now include patients in the decision-making process. And so I think because we include patients in the decision-making process, there is much more of a conversation involved than there is anything else. And I think that, so I think that that has been a stark difference in the way that we practice medicine over time. And I think just including people, and then when you include the patients, you're including the families, and there's different conversations and reactions with the families. And then I think in addition to that, the current time, right, we've just made it through COVID. We're all tired. There's been a huge amount of stress on ourselves, our families, the hospital system. And I think when you kind of look at the, and then, so if you're going to ground it within patient factors, physician factors and situational factors, lots of patients had to be put off or weren't diagnosed in time. Nobody's fault, right? It just happened this way. I think that that has actually also contributed to these big emotions that we all experience when we see people.
Thanks so much, Jennifer. Great talk.
Anybody else with a question? All right. Thank you so much, everybody. Oh, sorry.